Good evening all, my name is Dr. Arun Kumar K from the Department of Emergency Medicine. So today the discussion topic is more of how to recognize a sick child from ER. So this is more of a clinically oriented topic. The most common mantra which has been practiced in almost every emergency department is children are not just small adults. Why this is because children definitely they have a definite separate anatomical, physiological and a pathophysiological differences from the adults. So their way of presentation, their differential diagnosis, how to treat them, the drug dosing, everything will be like unique and separate. So you need to know how to deal with a child when a patient is sick. So we'll start with two case scenarios. We have a 3-year-old asthmatic girl brought to the emergency department with history of increasing breathlessness and incessant cry since early morning. How to evaluate this child and triage the patient. Case 2, it's an 11-month-old baby brought to the ED with acute onset respiratory distress and fever. Since the morning, he had crying incessantly and was not recognizing his mother. En route to the hospital, he had developed posturing also. Now this patient has been presented to the ER. How to evaluate this child and manage the patient. To start with evaluating, we need something called as pediatric assessment triangle. Now that is the core topic which will be discussed in this whole 15-minute presentation. Now pediatric assessment triangle is a rapid assessment tool and which has to be performed within the first 60 seconds. Now this has 3 observations which can quickly identify a child with having more of respiratory or circulatory compromise and which helps us to intervene immediately and stabilize a child. So what are the 3 components? The 3 components are A, appearance of the child, B, breathing with airway, circulation, C. Now you start with appearance. What do you see in a child with basically presenting with all the symptoms suggestive of asthma? Appearance, basically we have a mnemonic called as TICLS, T-I-C-L-S. TICLS means basically T for tone, I for interactiveness, consolability, look or gaze, speech or cry. So when you deal with infants or child's muscle tone, a vigorous child or a vigorous movement and normal muscle tone are reassuring that okay, the child is not so sick compared to a child who is having decreased muscle tone or appearing limp and weak. Now interactiveness, is a child playful or is a child is interactive? Now if the child is playful or interactive, he should not be categorized as sick child. Whereas if the patient is a bit anxious or patient is not able to respond to what the caregiver or doctor is saying, then it means something sick the child has. Consolability. Can the child be consoled or distracted by a patient or a caregiver? Look or gaze. Now an unresponsive stare, suppose the patient might be having post-ictal confusion in which he might be having unresponsive stare. That means he is having altered mental status. So that means the child is sick. Speech or cry. Whether the child is crying loud and strong, that means he has good muscle tone, he is responding. And if the child is crying inconsolably, that means there is something serious going on in us. Or if when you say something about the cry, if the child is having hoarse voice or muffled voice, that means there is definitely some sort of airway obstruction, possibly an upper airway obstruction. So when you look upon interactiveness, there is something called as AVPU scoring system. So what is the AVPU scoring system? A for alert, V for response to voice, P for response to pain, and unresponsiveness. Now alertness, basically it's been assessed by age appropriate interaction of the child to either to his parents or to his doctors. Now there is one point to be remembered is altered level of consciousness is the most earliest marker for hypoxia or shock. Response to voice, recognition of mental status to responsive to voice. That's what it means. So if an infant with minor symptoms continue to cry despite being cuddled, and so you have to evaluate whether the patient has some sort of systemic illness or something like reversible factors like fever, pain, dehydration, etc. And finally, unresponsiveness. So there are some red flag signs which has to be considered. That means if the patient is having incessant cry, patient is lethargic or excessive drowsiness, and the most important of all is if there is sudden flexure or extensor stiffening associated with an upward gaze or hypotonia in a neurologically normal child, that means we are definitely dealing with something like a respiratory failure or a hypotensive shock, which could be either because of secondary to either sepsis, hypovolemia, or near fetal asthma. Now, when you talk about altered mentation, you have to know what are the signs of reduced cerebral perfusion or cerebral hyperperfusion. In case of children, it could be either a weak cry or inability to recognize the mother or a vacant stare, inability to sit or walk, thirst for water, agitation, altered mental status, fighting for the O2 mass which has been kept for oxygenation, or confusion altering with drowsiness. Now, when you talk about cerebral hyperperfusion, you definitely will have an urge to give anti-epileptic or anti-epileptics when a febrile infant who presents with squirming movements or upward gaze, which is confirmatory to be atypical febrile seizures. In this case, if you give anti-epileptic, child will again deteriorate. Now, a neurologically normal child developing difficulty in standing or sitting position without support is being carried to the hospital or to the emergency department. That means definitely there is some sort of a critical illness going on with the child. Next comes unresponsiveness. Unresponsiveness, all abnormal movements in an unresponsive child are not seizures. Upward gaze with extensive stiffening or flexor spasm of the limbs can occur in hypoxia or shock even. So definitely we need to have a targeted history and rapid cardiopulmonary assessment to be done. So inadvertent use of anti-epileptics or anticonvulsant drugs in case of patient going for posturing secondary to either hypoxia or hypotension or shock can be definitely lethal. At the same time, if the patient presents to you with sudden unresponsiveness in the absence of any precipitating events in a previously normal child, that means the child could be having non-convulsive status epilepticus, in which definitely anticonvulsants are the life-saving drug of choice. So, failure to regain baseline consciousness after a brief GTCS is definitely indicative of NCSA or non-convulsive status epilepticus. Acute posturing and abnormal eye movements can occur due to even overdose of phenothiazine drugs like chlorpromazine, etc., which has been given as antihistamines in children. That's also another cause for posturing of the child. Now we have n number of causes. So one of the most common causes are basically the history of fever, breathlessness, acute watery diarrhea, followed by acute loss of consciousness. Now this is more suggestive to be shock or hypoxia. So all these symptoms basically guarantee us not every posturing or not every altered mental status can be because of just seizure. So we have finished appearance. Now we'll start with breathing. So breathing always includes, you assess the airway and the breathing techniques. So when you assess the airway, the most important 3 or 4 things which we consider is, one is the child crying, or if the child is vocalization is okay. If the child is speaking around, if he is making noise and all, that means airway should be patent. Now, there are certain added sounds which has to be considered lethal. For example, harsh inspiratory sounds, which is more suggestive to be stridor. It could be secondary to an airway obstruction. Now, snoring. Now, why the patient is snoring is mainly because patient could be having secretions, could be having falling back of tongue because of seizure previously. That's also lethal. So whenever a child comes to the emergency department who is unconscious or posturing, you assume that airway is unmaintainable. That's what the crux is. So other parameters which you use for breathing technique is, one is airway sounds. Now airway sounds, you have abnormal airway sounds which can be heard without even using a stethoscope. For in case you can he has stridor, snoring, grunting, even wheezing also. So another muscle tone, accessory muscle tone use definitely is, you can definitely see the child using, in case of inadequate oxygenation or ventilation, the child may be using accessory muscles like supraclavicular muscles, intercostal muscles, substernal group of muscles. It's used by the child to increase the tidal volume. So you can see retractions also. So retractions result from the use of accessory muscles. Now they can be supraclavicular, it can be substernal, or it can be even intercostal also. So severe retractions of more than one group of muscles is suggestive that the child might be affected with significant hypoxia. So the red flag is basically if the respiratory rate appears to be normal for age but is associated with unstable airway, shock and unresponsiveness. That means the child is going for respiratory arrest and impending respiratory failure. So that child has to be initiated on back mask ventilation. Next is circulation. Circulation, the most important parameter which we use for assessment is heart rate. Now heart rate, it can be either tachycardia or bradycardia according to the age groups. Now tachycardia, the earliest compensated response to decreased stroke volume or hypoxemia is tachycardia. So when a patient presents with tachycardia, you have to rule out fever, anxiety, pain, probably it could be because of sepsis also, and seizure also. So you need to know what are the causes of relative bradycardia with shock. Now the deadly causes which we encounter in ER is, one is raised intracranial pressure, second is hypothermia, third is electrical disturbance like hypokalemia, dengue shock syndrome, drug intoxicity like probably digoxin and beta blockers. So you have to consider when a patient's presence with bradycardia with shock, all these causes. The next thing is comparison of pulses. Now comparison of pulses, you have either weak or absent pulses. A weak pulse is mostly because of peripheral vasoconstriction because of a whole lot of reasons. If the child is present with absent distal pulse, that means he will be definitely in decompensated shock. So loss of central pulse definitely will require immediate intervention. So when a patient presents with bounding central pulse or distal pulse, it is mostly associated with tachypnea, tachycardia and altered mental status, which is most suggestive to be hypodynamic circulation with low systemic vascular resistance. So here the red flag sign is any history of early loss of consciousness, abnormal cardiopulmonary cerebral assessment, palpable posterior tibial artery with difficulty to feel dorsal aspiratus, definitely you are looking into a shocked patient. So other parameters which are used in circulation is core peripheral temperature gap. So whenever a patient presents the difference of core and a peripheral temperature gap of more than 2 degrees Celsius, it's a sign of low perfusion. The second thing is capillary refill time. Capillary refill time, the normal CRT is less than 2 seconds. So if it is prolonged, it means that you are dealing with either a fever patient or a shock patient or probably a cold ambient temperature also. Now how do you assess? Basically you are lifting the extremity slightly above the level of heart and then you apply enough pressure to blanch the skin and then you see it, how the CRT is. Blood pressure. Blood pressure, you have for children, hypotension is defined as a systolic blood pressure less than 5th percentile of the normal for age group. So if you take into consideration neonates, less than 60 mm mercury, infants less than 70 mm mercury, less than 2 years of age, 1 to 10 years of age, it's like a formula called as 70 mm mercury plus 2 into age in years, and if it is 10 years and older, it is 90 mm mercury. So what are the common presentations of shock in children? One is, as we told earlier, tachycardia, skin changes like mottling or dry skin or dry mucous membrane, impaired mental status, oliguria, and finally lactic acidosis in late presentation. So we have dealt with A, B, C, that is appearance, breathing, which includes airway also, and then circulation. So there is something called as extended fat triangle in which we include disability also. So in disability, basically what we see is the position of eyes, meaning the pupillary examination. So you examine the eyes, you examine any sort of abnormal eye movements and how the pupils respond to the light. So what's more important is eye signs in children presenting with severe cardiopulmonary failure in the absence of any seizure history is been associated with increased risk of mortality. So we have seen the first case itself, a child presenting with near-fatal asthma, presenting to the emergency department with ocular movements, probably some sort of nystagmus. So that means the child is going for hypoxia, going for altered mentation. So most of the doctors, probably in the emergency department, not properly trained in pediatric emergency medicine, will be assuming that child might be seizing. So in that case, if you give anti-epileptic agent, definitely the child is going to crash. So this is where you are supposed to know what exactly the child is dealing with. Is there any cause for any sort of abnormal eye movements? Are we dealing with hypoxia? Are we dealing with any shock? So you need to treat what exactly the cause of abnormal eye movements are. So that is where the importance of PAT triangle comes. So this is why pediatric emergency medicine is so critical in dealing in the emergency department. Until unless you know the stuff, you're treating the wrong patient and the wrong diagnosis. Thank you.